No, thank you very much. Can everyone hear me and see my slides?
Yes.
Okay. No, thank you. No, I also found it very interesting, like where my talk was positioned after all these exciting talks about how exciting our future is going to be and how we are going to solve the problem of cancer. I guess I'm going to talk about uh, probably we should not be too excited, and we should also think about the ground reality and how we can make everything accessible to everyone, and try to cover the ground before shooting for the moon. So thank you very much for this opportunity. I have no financial disclosures relevant to this topic. So we see all these exciting headlines in the media about how we are going to solve the problem of cancer in the near future, which is exciting, which I also get excited about this. But the problem I see is despite all these exciting updates and headlines, are our patients actually having better outcomes? Are the outcomes improving for the patients in the real world for the majority of the patients? And the answer, unfortunately, is not yet. And if we look at the data, the average improvement in survival through all these exciting new drugs that have been approved by the FDA is a little less than 3 months. In Canada, based on our Canadian data, it's 3.7 months, which is not nothing, but it's not like several years that we would have otherwise liked to see. So where is the problem? And is the problem the lack of investment? Is it because we are not investing heavily on drug development? And the answer is no, because we have been investing a lot on drug development. If you look at this paper that was published in JAMA Health Forum 2 years ago, where they plot cancer expenditure per capita for high-income countries across the world, and they looked at the adjusted cancer mortality rate, this is adjusted by smoking, you see that there is actually no good correlation between how much a country spends per person on cancer treatment versus how much mortality rates they have achieved. And if you look at the US, US spends almost 200 billion US dollars. It's almost $600 per person on cancer, of which 10%, almost 21 billion US dollars, is prescription drugs alone. But are we getting the juice out of the squeeze? You can see several countries here on the left that are not spending as much, but have outcomes even better than that of the US. So we see that there is no good correlation between how much we are spending and how much we are improving outcomes for our patients. And as we have discussed, the average life expectancy that our drugs have improved is not very encouraging. It's a little bit disappointing when you look at the average. So the question that we are asking is, why are some of our cancer drugs not delivering on the promise? We are seeing all these exciting headlines, but why? Why is this not translating into reality? So there are a number of reasons. First, we see that some of the drugs, they look exciting in the trials. The results look fantastic, but the trials are flawed in the design and reporting. So it does not actually translate into meaningful outcomes for the patients. And then there is the role of experts like ourselves who want to oversell the promise of the results. And then there is the role of media in hyping some of these results. And then there is the role of education overall. This is education for physicians, for trainees, for the patient communities, and for everyone. So how do we reconcile all of these? So this is about, I'll be talking about each of these points that I talked about. Trial design flaws, for example. We published this paper as a part of the ESMO magnitude of clinical benefit scale working group, in which we looked at several items that could possibly inflate the results that we see in the trial and that may not translate into the real world. And to give you some of the examples, like, sometimes we are approving drugs even without randomized trials. Some randomized trials are using a control arm that has already been outdated. Sometimes we are not measuring what matters to the patients in the trials. Some trials have very narrow eligibility criteria so that it does not translate into the real world. Some non-inferiority trials are using overly lenient criteria for defining non-inferiority. There is inappropriate use of the crossover design. Patients are not getting the standard treatment after the protocol, after the clinical trial, post-protocol treatment. There is informative censoring in the trial, and so on and so forth. There are several issues that can lead to flawed interpretation of the results of the trial. And then we talked about the role of media. I'll give you some examples. Like there was this headline. This is not about from colon cancer, but this makes the point very well. The headline said, "Remarkable therapy beats terminal breast cancer." What's not to like about it? It's fantastic. It's a remarkable therapy. It beats a terminal cancer. And then if you look at what was the publication that led to this headline, you see that it was a paper in Nature Medicine and it had received excellent online attention. This is the altmetric score, which tells you how much of media attention a certain paper gets. So it had fantastic media attention. But if you look into the paper, then this is the result. This whole thing was driven by one case report. This is the story of one patient. It's not even plural, it's a patient, it's not even patients. And this leads to such exciting headlines in the media, and the patients will read about this and they will ask and they will demand this treatment. So which is based off of just one patient. One more example. This is from prostate cancer. Again, exciting headlines. Prostate cancer laser treatment could be a game changer for men. It's a leap forward. What's there not to like about these headlines? It's fantastic. But again, if you look at what study are forming these headlines, it's this paper that I have put on the top of the screen. It's about a drug called padaliporfin vascular targeted photodynamic therapy versus active surveillance. Now, if you look at the results, what are the results that led to such exciting headlines, calling this drug a leap forward or a game changer? Again, received excellent media attention. The altmetric score, anything over 1,000 is amazing. Now let's look at the results. These are the results. Now, as you can see here, the control arm here is active surveillance. That means it's not any active cancer drug therapy. It's not any cancer-directed treatment, but just we are watching the patient carefully. That means we are not actively doing anything. So compared to not doing anything, if you give this fancy new drug, what happens? Look at this, metastasis. The number of patients who develop metastasis in either group is 0. The number of patients who die from prostate cancer in either group is 0. That means even if you don't treat them, no patient is going to develop metastasis. No patient is going to die from this cancer. So how can it be a game changer? There was no game to begin with. How can you improve on a mortality rate of 0? You can't have a mortality rate of negative. So, this is giving an example of how media headlines can be misleading. And as I mentioned in the beginning, I refer to this as the cancer ground shot movement because we have been chasing moonshots with all these fancy new technologies and trying to, persuade ourselves that we are going to solve the problem of cancer using every time there is a new technology, immunotherapy, CAR T cells, artificial intelligence. But the ground reality is that many patients in the world are dying not because they don't have access to these fancy new things, but because they don't have access to proven treatments that we already know to work. If you look at the status of global surgery, global radiotherapy, there are several countries in the world without a single radiotherapy machine. So we have been arguing that we need cancer ground shot as much as we need cancer moonshots if we are looking into global spectrum of the disease. And then, we published this paper now, I think 5 years ago about cancer treatment in the last 6 months of life. You could argue last 6 months of life, last 3 months of life, the theme is the same. We have been, it's very easy to keep prescribing one more drug, one more new therapy for the patient until the very end of their life. But it's very difficult to actually have that honest conversation and focus on quality of life and what matters to them. This is a headline that I took from New York Times. This must have been 3-4 years ago, and they termed this practice as desperation oncology instead of evidence-based oncology. They call it desperation oncology. And one of the statements in this article, you can Google it and read the whole article. This was from New York Times, but one of the statements in that article, it particularly touched me in a very sad way. It said, "Do you want to?" It was quoting some physicians who would say this to the patient. "Do you want to try an immunotherapy drug before you die?" So this whole practice of what they termed as desperation oncology is something that we as oncology community should be very, very cognizant of and careful about, because I believe that this is mismatch of priorities. We are not prioritizing properly this is a colon cancer symposium. So to give examples from colon cancer, for example, the mismatch of priority, as in there is lack of access to good quality pathology and adjuvant chemo in several parts of the world, in low and middle income countries. But at the same setting, they are talking about having access to robotic surgery, all these fancy new things. To give example of a drug therapy, because I'm a medical oncologist, we don't have access to immunotherapy for MSI high advanced colon cancer, for example, in several parts of the world, but people are having access to drugs like regorafenib. I'll give you a real life example from here in Canada. I practice in low income country as well as in Canada, so I'm giving examples from different settings in the world. I'll give you a real life example. I have a patient, 82-year-old patient with metastatic colon cancer. This was a patient I saw a couple of weeks ago who has progressed on 2 lines of chemo. He lives alone. For me, it's very easy to prescribe him the third line of treatment, TAS-102 plus bevacizumab. It has been funded. It costs $100K, $100,000 a year if I were to prescribe this, but it's not a big deal. Like I can, with 4 or 5 clicks on the computer, this gets done. But he's an 82-year-old man living alone, and his priority is actually to get support in his daily life. I do not, our society, our system does not have the funds to offer him a support worker to help with that, to do groceries, to help with any other daily needs. And that would have taken, I don't know, 40, 50K US dollars a year, even to have someone help him full time. But it's far more easier for me to prescribe him one more drug that costs 2, 3, 4 times more expenses to the healthcare system than to do something that is non-drug therapy, but actually helps him and improves his quality of life. So, these things get me thinking. As an oncology community, we have so much of talent, energy, and resources. Should we really focus all of that on another Me Too drug that improves survival by 3 weeks? Is that where we should be focusing our energy on? Back in 2017, when I was writing blogs for eCancer, in one of the blogs, I mentioned that, maybe one day we'd want to start a center for sense in oncology, because it felt like common sense to me that our goal is to help patients, help improve the outcomes that matter to them, and not just say it's some arbitrary radiological metric. And 3 years ago, we published this in Nature Medicine, where we provocatively titled it "A Common Sense Revolution in Oncology," because this was intentionally, like a satire, because cancer treatment should benefit patients, and that should be common sense that our treatment should benefit patients. But if we say that, some people think it's revolutionary. So in this paper, we propose 3 dimensions where we can work on: in the delivery of care, in research and policy, and education. And then this sort of movement took off, and we had people from all over the world supporting us in this, and we wanted to formalize it into a movement. So in 2023 in Kingston, this group of people representing physicians, patients, advocates, journals, and other stakeholders from all over the world, we came together in Kingston, Ontario, Canada, back in 2023 April, and we formed this movement called Common Sense Oncology. And then these are the founding members of Common Sense Oncology. And then we published our sort of manifesto in Lancet Oncology after that. And I want to highlight a couple of things that we have published in our manifesto. You can read the whole paper, but our mission is to ensure that cancer care focuses on outcomes that matter to patients. That's our mission. And our vision is that patients should have access to cancer treatments that provide meaningful improvements in those outcomes, irrespective of where they live or what health system they get treated in. So we have several points that we have covered under this, but our guiding principles is that access to quality cancer care should be a fundamental basic human right. Patient and societal needs is what should be driving cancer research and delivery of care. Patient and public involvement is essential to make these policy decisions. Patients should reasonably be able to expect that the treatments they are getting meaningfully improve their survival or quality of life. There should be shared decision-making grounded in evidence. And cancer treatment should be fairly priced for the context in which they are used. And there should be equity in access to health, high quality care, and comprehensive patient-centered care should include not just drug therapy, but also psychosocial oncology, survivorship, and palliative care. So we established this in 2023 April. What have we been doing so far since then? It has been 1.5 years. So we have started working on 3 core pillars of our work. The first is evidence generation. So we want to ensure that clinical trials use and report outcomes that matter. Then we are working also on evidence interpretation, how we promote critical thinking in oncology, and evidence communication, how we communicate that properly with patients, public, and the policymakers. So we have 5 project teams that have been working on these issues. There is Project RCT, which is producing a checklist, sort of the consort diagram for cancer drug trials. There is a project team on cancer education, how we promote these things into the fellowship trainings. There is a stakeholder engagement team. There is patient priorities team that is being led by our patient advocates and partners. And there is the policy and politics team. Just to give you a couple of examples, for example, the patient priorities team has been working on producing like a guidance document that will help patients to ask good questions when they are faced with the diagnosis of cancer. For example, what are the most important questions someone should ask when they are meeting an oncologist for the first time, and so on. Just to give you a sample, we had published this back in 2019 about what are the key questions a patient should consider when they're enrolling into a clinical trial. So similarly, we are going to make a number of different versions of this for when they are diagnosed with cancer, when the cancer has progressed, and so on. So our bottom line is this. Common sense oncology will promote interventions that improve the lives of the patients. We'll celebrate well-conducted trials and promote effective interventions, but we'll also speak about and challenge interventions that might cause more harm than good. We will seek to decrease global and regional inequities in access to affordable, high-quality care, and improvement in generation, interpretation, and communication of evidence will help to close these gaps and move our field closer to a future in which a patient's outcome is not determined by where they live, what they can afford, or the strength of a marketing campaign. So I'd like to encourage you all to check out our website or follow us on social media too. And we'll be happy to take this discussion further. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.